We're talking about syncope, and we're going to focus for a few minutes on causes of syncope. By the end of this video, you should be able to list the common causes of syncope and summarize the basic pathophysiology. You'll be able to list specific examples of conditions that cause syncope and to differentiate associated features of different causes of syncope. There are many causes of syncope, but there's only one final common pathway, and that is decreased blood flow either to the cerebral cortices or the reticular activating system. There can be many different reasons for this decreased blood flow state, but let's focus on just the 5 major categories: cardiac, neural reflex, orthostatic, and then less commonly, neurological causes, as well as psychiatric or behavioral causes. First, let's talk about cardiac causes of syncope. In the ED, when we encounter any syncope, we ask, is it cardiac? That's because cardiac syncope is concerning. Cardiac syncope is associated with a greater than 10% 6-month mortality rate. That's not to say that other causes of syncope can't also be concerning. For example, someone having a brainstem stroke may lose consciousness, and that's a very concerning clinical scenario. However, when we look at life-threatening causes of pure syncope, most of the time these are from some cardiac cause. Other things should be at the back of our minds, and we should be looking for associated symptoms that might point us in another direction. But the big differentiation that we usually have to make in the ED is cardiac versus benign. Cardiac syncope is often associated with exertion, and we can divide cardiac syncope further into syncope caused by a structural problem versus syncope caused by dysrhythmia. Examples of structural cardiac issues that can cause syncope include aortic stenosis, hypertrophic obstructive cardiomyopathy, pulmonary embolism, MI or acute coronary syndrome, and AAA. Examples of dysrhythmias that can cause syncope include both tachy and bradyarrhythmias. Any of these cardiac issues can lead to a decrease in cardiac output, especially during times of physical exertion, which leads to our final common pathway of decreased blood flow to the brain and syncope. Next, we'll talk about some neural reflex causes of syncope. This category includes the common vasovagal syncope. Neuroreflex syncope just means that there is some inappropriate vagal or sympathetic tone, each of which can lead to bradycardia or vasodilation, leading yet again to our final common pathway and syncope. This pathway can be triggered by all sorts of different things, including strong emotions, like getting scared by a ghost, or coughing, or peeing, or even swallowing. Any of these can trigger inappropriate neural tone accompanied by the slow onset of the classic prodrome, symptoms such as nausea, diaphoresis, and lightheadedness. Now on to orthostatic syncope, which typically occurs after a positional change, such as rising to a standing position. If such a change is accompanied by insufficient autonomic response, the result will be an effective decrease in cardiac output, leading once again to our final common pathway. Orthostatic syncope may be caused by medications, or it may signal a more sinister underlying pathology, such as volume depletion from a bleed or sepsis. Next, we have the neurological causes of syncope. Although these tend to have other obvious associated symptoms and are therefore not a common cause of pure syncope. Examples include brainstem ischemia, typically associated with vertigo, subarachnoid hemorrhage and basilar migraine, both typically occurring with severe headache, and the rare subclavian steal syndrome. Lastly, it's important to mention some psychiatric and behavioral causes of syncope. We know that children sometimes breath hold, leading them to pass out, and individuals of all ages may hyperventilate during a panic attack, leading to hypocarbia, cerebral vasoconstriction, and the common final pathway to syncope. At this point, you may be confused. With all of these possible causes of syncope, you may be wondering, how can I ever figure this out in the ED? A place where you are expected to see patients quickly and determine a disposition based often on an incomplete clinical picture. Well, the answer is, you don't have to. You don't have to figure it all out in the ED. Instead of asking, what exactly is going on? In the ED, we often ask, do I need to admit this patient? Or, in the case of syncope, is it likely to be cardiac? So, while we need to have all of these possible causes of syncope in the back of our minds, cardiac, neural reflex, orthostatic, neurologic, psychiatric, we may not even arrive at a diagnosis in the ED. And that's okay, as long as we can figure out how risky it is to let the patient return home, and if that risk is too high, we can admit them. So to help us make this decision about whether to admit the patient, let's talk next about our clinical decision rules.